Welcome to the CME accredited video roundtable discussion titled Community Oncology Clinical Debates, Chronic Myeloid Leukemia. I'm Dr. Michael Deininger from the University of Utah Huntsman Cancer Institute, and I'm joined by Dr. Cherry Radich from the Fred Hutchinson Cancer Research Center in Seattle and Dr. Gail Robos from Weill Medical College of Cornell University in New York City. Welcome both of you, and thank you very much for joining me. The learning objectives of our debate are to assess the patient and disease characteristics for selecting optimal frontline therapy for patients with CML, to evaluate the role of mutational analysis for individualizing therapy choices for patients with CML, and identify investigational agents in clinical development for patients with that disease. Just to give a brief introduction to CML, in the US we look at about 5,000 cases in 2010 and probably about the same number in 2012. That's about 15% of all adult leukemias. The incidence does increase significantly with age. We now look at a median age at diagnosis of 67 years. The prevalence is strongly increasing due to effective therapies available. Most patients do present in the chronic phase of the disease, and still the majority of death due to CML are caused by progression to accelerated vasoblast crisis. Importantly, about 50% of all patients are completely asymptomatic at diagnosis and are picked up on routine blood counts. Our first clinical debate is entitled, How do we choose the optimal frontline therapy for patients with CML? And my first question goes to Dr. Cherry Radich. And the question is, how can you avoid diagnostic pitfalls? How do you use RT-PCR versus fluorescence in situ hybridization versus bone marrow biopsy to make the diagnosis?
All right, so if we're concentrating on making the diagnosis, I think the important thing is that even in the era of modern molecular biology, with BCR-ABL, FISH, and PCR available, the standard of diagnosis is still to get a bone marrow. And the reasons are twofold. One, sometimes you can be fooled by peripheral blood findings, and the bone marrow will tell you both the pathology, the histochemistry, et cetera, that will be characteristics of CML. But most importantly is PCR and FISH look just at the BCR-ABL. It can tell you just whether it's present or absent in the quantity. It doesn't tell you the blast count, though, and that's really the most important thing in the diagnostic marrow, to make sure that someone is in chronic phase rather than accelerated phase of blast crisis, because that's going to completely drive your decision-making, not only about what drugs you may be starting with, but where you see transplantation as follow-up. So you have to really nail the diagnosis of chronic phase versus advanced phase, and the only way that you can do that is by doing a bone marrow biopsy with conventional cytogenetics.
So Dr. Robos, is that common practice in your place as well?
Absolutely. We do start with bone marrow biopsy, and I think that the common problem now is that because the more sensitive testing of PCR and FISH are available and can be done in the peripheral blood, that unfortunately leads to a leap that, well, maybe we can skip a bone marrow biopsy. They're a little bit more unpleasant. Maybe we can avoid a procedure for the patient and just go to something that can be checked in the peripheral blood. The problem with that is that it's actually doing the patient a really big disservice, because the information at the beginning, as was just mentioned, about the pathology, about is there any fibrosis, is the blast count elevated, are there other cytogenetic abnormalities at the time of diagnosis, these are very important both for initial therapy and for subsequent management. And the patients who are not offered that right from the beginning actually miss out. Also, we can't promise patients that follow-up bone marrow biopsies won't be required later in their therapy. And the standard of care is not to only do one at the beginning. There are follow-up marrows as therapy proceeds. So I think that to give the patient the impression that the test can be avoided throughout their care is completely wrong.
Right, so there's only one opportunity to get it right.
That's right.
Okay.
That's right.
So I think there's complete agreement on that. Along the same lines, so how do we define hematologic, cytogenetic, and molecular responses well, from your Weill Cornell experience?
From Weill Cornell, and I think that everybody is trying to get onto the same page in following guidelines, because this is very important for patients too, to be able to monitor along with us exactly what's happening during their treatment course. And I think that we've all seen that the NCCN and also the European Leukemia Net are trying to stay up to date and publish refined and updated guidelines of exactly what hematologic, cytogenetic, and molecular responses are. And hematologic response doesn't just mean that your blood counts are better. They have to be completely better. And cytogenetic responses doesn't mean they're a little better or partially better. They're defined very specifically according to how many metaphases have normalized. And I think that it's important for patients and doctors to follow the checkboxes quite exactly so that they can determine at the defined intervals, 3 months, 6 months, 12 months, exactly are they meeting major responses, are they meeting complete responses, both for molecular measuring and for cytogenetics.
Jerry, I mean, you've been involved in PCR testing for a long time, and sometimes I feel there's a lot of confusion out there. There's international scale or other scales.
Everyone agrees that PCR testing is the most sensitive test. That's nailed down. And many studies have showed that both achieving milestones, for instance, major molecular response, has meaning.
But what is that, a major molecular response?
So how that is defined is and it's somewhat originally arbitrarily defined, is as a 3-log reduction from a standardized baseline. Not of the patient's individual baseline, but it was an aggregate baseline from the Imer study, right? So that's been sort of artificially determined. So now what has been done is to try to get many labs on the same scale, the so-called international scale. Problem is that very few labs in the United States actually have an international scale. Probably about 6 or 7 right now. Finally, some companies have been developing World Health Organization standards that will be able to disperse to all labs. So I think within a couple of years, all labs will actually be able to be compatible. But that's something that investigators have to really think about in the community, is that if you're doing PCR testing, to make sure it's always going to the same lab.
One of the things that I think is particularly frustrating about the PCR monitoring, and we see many consultations for this, is that it's an undulating baseline. One has to be very careful about recommending a therapeutic change for a patient, and I have to say that there are an awful lot of shifts in therapy that could probably be avoided.
There's an awful lot of panic or reflex reaction to changing PCRs, and as Gail has mentioned, there is a fluctuation. Some of it can be from actual test variations, because all tests have. Some of it can actually be the biology of disease. I mean, in the years before we treated patients, when we just treated with the hydroxyurea, at diagnosis, patients' white counts have 10 to 20-fold variations in cycles, and so that may still be going on. You may see rises and falls in low-level BCR-ABL just from the actual biology of the disease itself. And of course, the other thing that we'll talk about probably later is compliance issue. One of the main reasons that I see BCR-ABL levels climbing is when sometimes people decide to take them a drug holiday.
If you put all that together, like put together all these disease characteristics, cytogenetics, maybe even mutational analysis, patient history, to make therapeutic choices. Jerry, how would you do that? What are the critical parameters you
So if we have someone
at
at diagnosis, I mean, the main thing obviously is phase of disease. So once we get people, and we're talking about accelerated phase blast crisis, that puts them into a different bin where they need a TKI and then a transplant, most likely. If we're talking about chronic phase, then we have now 3 approved drugs that we can deal with, the imatinib, nilotinib, dasatinib. And how would you use patient characteristics at diagnosis to influence those? That's a bit more tricky. I think one of the major ways that many of us use is by clinical scores, like the SOCOL score. So whereas in a patient with a low SOCOL score, which has a lower risk of progression, those patients, many investigators would start even with imatinib now and follow closely by monitoring and change if needed. I think many people, if someone came in with an intermediate or high-risk SOCOL, which have a higher risk of progression, might go to this stronger second-generation drugs right off the bat.
I think one of the things that you brought up in your initial question was we're used to it that we have a bone marrow biopsy, we have an aspiration, we have cytogenetics, we have a patient in front of us who may be variably symptomatic, may have splenomegaly, may not. But I think that the part that makes it hard right now, and lots of questions come in about what to do with a mutational analysis. That is a test that is available. It can be sent. But the question is, should we send it right from the beginning as we're sitting in the room and calculating a SOCOL score and putting together all the things that we're used to looking at? What do we do with the mutational analysis up front? And I think that's a pretty controversial subject where investigators mostly agree. And if you get all of us in a room, there will be a lot of head shaking and people will say, well, there are no data to support upfront mutational analyses for newly diagnosed patients, and that the frequency of the gatekeeper or T315, more dangerous mutations to which current therapies unfortunately don't help. That's a low frequency. It's not an indication to do mutational analysis up front, and we don't really know enough to drive our choice. And that's probably the board's answer for 2012, and we probably would all nod with that. The problem is that that's really hard for patients, and it's hard for doctors who don't treat a ton of CML because, well, what if I did have that? What if I would be the one? And what's the reason not to send a mutational analysis? Isn't it just another test? Isn't it just money? So I do think it's an important question, and I think it is likely that in the next several years we will at least be able to be a little bit better about guessing for changes in therapy, which mutations might possibly help us make a decision to change therapy. I still think for upfront, though, unless there are very, very special clinical circumstances that mean that we would just have to know up front whether there was any possibility of having gatekeeper mutation, and there are some clinical scenarios either with potential difficulty in finding a transplant match in a particularly high-risk patient, or one can imagine scenarios where you would give in and say, okay, I'm going to check up front. Most of the time, though, we don't.
One thing we didn't talk about that I think that's really crucial in clinical is the patient's age. Our whole fight here is to keep someone from going to accelerated phase of blast crisis, and that's a link to time in any way. My goals in treating a 20-year-old are a little bit different than a 75-year-old. So I think that the younger patient I would be more inclined to give stronger agents to.
What are the really convincing data that you think this is hard enough to tell a patient you need to maybe accept more copay and go on nilotinib or dasatinib as a frontline therapy? What would you say?
I think the data are increasing to indicate that the rapidity and the depth of major molecular responses matter. I think that originally there are certainly no obvious measurements of overall survival that are driving these data yet. But I think overall survival is a tricky endpoint in CML, especially for younger patients. And I think that there have been a proliferation of papers suggesting that it probably does matter to get into a deep, quick response. That said, I think the age factor is very important, and I think that for lower risk patients, I don't think it's a slam dunk, and I think that for some patients the copay issues actually may not be worth it. Bankrupting the family may not actually help for patients who are predicted to do extremely well on imatinib, which, by the way, remains a really good drug, and in a lot of ways easier to handle than some of the other choices. I think patient factors are very important in selecting the therapy in addition to predictions of response, because there are issues, for example, nilotinib requires quite careful attention to be paid about when you take it during the day, how you take it with food. There are patients with medical comorbidities, diabetics, other type of comorbidities who find that very challenging. And if you're not taking the drug, then it doesn't matter how good it is, it's not going to work. And I think that selecting a therapy for a patient based on their predicted compliance does matter a lot.
The data is quite clear that when you look at short-term indications, for instance, cytogenetic response, molecular response, progression-free survival, the second-generation drugs have a bit of an advantage, right? But as Gil said, overall survival we don't know yet, and often I find that patients come in and they almost sort of have walked themselves into a decision when they get in. And it basically breaks down to, the long-term complications of imatinib. You don't know the long-term complications of the second generations. I want to be conservative, right? Versus someone who says, well, if there's a stronger drug, line me up. I think that's a lot. That's a lot of a personal choice.
So along the same lines, in somebody who is on imatinib comes into your office, what are the really hard criteria to switch to a second line? So Jerry, from your experience, when do you consider switching?
There are strict endpoints from the ELN and the NCCN guidelines, right? So that's the fallback ones, which are basically, if they haven't had a complete hematological response at 3 months, if they don't have a major cytogenetic response, by 12 months, major molecular response by 18 months. Those are kind of hard failure versus non-failure. Those are pretty easy ones. We all look at whether you lose, if you have a major molecular response, if you lose that, those people are at a little bit higher risk of losing their cytogenetic response. There's no data that switching them at that point is going to prevent them from losing their response. There's a couple of trials out there finding that, right? So what usually happens in our setting is when someone actually walks in our door, they've usually actually lost their cytogenetic response or never achieved one in the first place. That's usually the setting when we actually find them. And that point is, the decision is pretty easy, right?
Well, I think you're making in my mind a very important point, that we really don't want to do cosmetics, kind of molecular cosmetics. I think it's really, in my mind, it's important to have hard endpoints so that you can tell the patient, if you achieve this response, this is really associated with better outcomes, better survival, better progression-free survival at the very least. So I think in my mind, it's critical to keep that apart. What is a molecular endpoint, and maybe we read choice about that, but it doesn't mean a lot for the patient in real life, versus these other endpoints that are really making differences.
Now the push from various pharmaceutical companies and the like will be looking at the data that's just come out of ASH, which suggests that if people don't respond by 3 months by PCR, they're going to have a hard outcome. So there's going to be a lot of push for people to change early based on that. But again, we don't know that those patients that don't respond to imatinib, for instance, at 3 months, whether they're magically going to respond to a second-generation drug. I mean, that's got to be part of a clinical trial, and I don't think that's something that people should be just doing, willy-nilly.
But at the same time, I think that it's really important to emphasize for patients who are doing well that they're doing well. I think that there was a huge pressure as these data have come out. There was a massive extrapolation that, well, wait a minute, we better switch. I've been on imatinib for 8 years. I'm doing well, but I better switch.
Yeah.
And that actually is the absolutely wrong thing to do. There are no data currently that they should jump ship and be switching to something else.
The question that I get frequently asked is, there are these new agents, and which one should I actually use? Dasatinib, nilotinib? Should I go on a clinical trial? So what's your practical answer to that?
So I think that it's very hard lately with the data emerging suggesting that the faster and deeper early responses matter. It's difficult these days not to use one of the newer generation TKIs up front. That doesn't mean that I don't believe in my heart of hearts that imatinib might work just fine for those patients, but practically speaking, for newly diagnosed patients, I do tend to choose between dasatinib and nilotinib, and I try to make my upfront choice based on lifestyle issues, medical comorbidities, and little hints that I might have from the patient as to which one might be easier than the other.
So could you give me an example for comorbidities that would sway you either way?
I think that if there would be a patient who really couldn't tolerate a pleural effusion, for example, if there would be either a cardiac or a pulmonary condition that would make it truly serious if they had even a small pleural effusion, I might shy away from dasatinib for that reason. I think that sometimes when there are patients on multiple other medications, taking something twice a day just becomes impossible, and that's a reason for some patients not to use the nilotinib. I don't actually believe that one of those is clearly better than the other. And I'm frequently asked the question that which one is better? And it's hard because they're both excellent drugs and they're very effective drugs. And it's very difficult to get pinned down in the which is better. But I do think that for the majority of patients who are newly diagnosed, they are going on to one of the newer agents. I think that it is the case that for much older patients, for those patients, often imatinib is the easiest one to handle, and I use that with absolutely no worry whatsoever. But I think that the younger ones also fall into a reading of the newspapers, reading of the data, and there's a lot of, I want to be in remission as fast and as deeply as possible.
Sometimes a community physician will have a lot of experience with one of them versus no experience with the other. And sometimes I tell people, look, if all things are equal and you've used this second-line therapy more and not the other one at all, and you're comfortable with knowing what the toxicity spectrum is and the response spectrum and all that kind of stuff you're used to, then all things being equal, go with the one you're comfortable with.
Okay, let's move on now to our case study. So this is about a 60-year-old gentleman who presents with a history of left-sided abdominal pain, poor appetite, and weight loss. His past medical history is significant for interstitial lung disease, right heart failure, and recurrent pleural effusions. A recent EKG shows a QTc interval of 433 milliseconds. Physical exam is significant for splenomegaly. Let's look at the lab findings. The hemoglobin is 10.1, white count is 321, platelets are 810. Differential shows 25% sacs, 23% bands, 70% myelocytes, 10% promyelocytes, 8% basophils, 6% monocytes, 4% lymphocytes, and 10% blasts. Bone marrow cytology reveals 7% blasts, 5% basophils, and cytogenetics is completely pH positive, but there are no additional cytogenetic abnormalities.
This case would make me, this kind of smells like it's a more advanced chronic phase. Especially with the spleen size, the white count, the blasts, which are kind of getting up there a little bit, right? And I'm calculating the so-called score quickly in my head. I think it's a high-risk case.
Right.
So I would be inclined to start this guy on a second-generation drug, frankly, just because I'm pretty worried about him. And given the pulmonary problems and the like, I'd probably think that dasatinib wouldn't be the best one to start, so I'd probably start with nilotinib. The QT interval stuff, all these drugs have QT interval problems, so I'm not terribly worried about that. If someone was really paranoid and worried about that because of nilotinib's black box indication, you could always start on imatinib and demand a really, really good response.
I think if one really does have a concern, either because they're on a medication that is known to prolong QT or because the patient has some cardiac issue, that's something which then in consultation with a cardiologist and really interpreting an EKG well, you can make a decision. But there are no data to suggest that in an average patient that nilotinib and QTc issues are particularly dangerous, more so than with other medications. And I think that the concept of just looking at an isolated QT measurement and making a decision solely on that basis that, oh, 433 looks a little bit long, that actually doesn't make any sense. I think in this case, what was driving maybe to push toward nilotinib instead of dasatinib was the fact that a patient like this might have difficulty tolerating an additional pleural effusion that was perhaps induced by the dasatinib. But I think even there, it's probably not an absolute contraindication. It's a relative clinical contraindication that you just don't feel like dealing with that as another problem and trying to figure out whether it's the drug or whether it's because he had one to begin with. But I agree that you look at somebody like this and say, there are a few extra blasts in there, there's a big spleen in there. This isn't somebody that you're going to feel confident is going to be smooth sailing into your first 3 or 6 months of therapy in terms of response. We'll probably go with a second generation.
Right. So just for the sake of completeness, what are the major clinical issues that would sway you towards dasatinib in any patient?
I think I usually do it at what sways me away rather than what sways me towards, since a lot of the outcomes are percentage-wise extremely close. we're dealing in a situation of effective therapies. You get excellent molecular responses in the newly diagnosed upfront setting. You have very low rates of progression to accelerated and blast phase disease. So I'm mostly looking for what makes it more difficult for me as a doctor to use this drug versus the other. Maybe, I don't know.
No, I mean, I'm a similar vein. You know, the things that might push me, if all things are equal, towards dasatinib, and this is just a slight nudge, the two things would be the once a day versus if a patient, it seems like they can't, you know, do the compliance issue. And I'm not sure how to define who those patients are, you know, whether they have messy cars or messy offices or how to define a good and poor compliance patient. The other thing is that if I really think someone is tipped over the edge and has gone to advanced phase disease, from a biological standpoint, in those cases, I sort of like the idea that dasatinib is more of a dirty tyrosine kinase and may be involved with, you know, blocking mechanisms that will block progression, and that's just based on molecular biology and nothing more.
So it's a kind of synopsis of patient's history, disease presentation, everything you can assess at the time of diagnosis, and then clinical judgment, really, because you don't have any direct comparison.